Yep, already.
Well, hello everybody, and welcome to the Brain Behavioral Institute Research Symposium. My name is Ludmila Bakireva. I'm professor at the College of Pharmacy and a BBHI co-director jointly with Dr. Kiran Bhaskar. I would like to welcome you to the BBHI Research Symposium focusing on novel solutions for clinical pain management. We plan to do several seminars with research seminars per year. And the next one is planned for October 19th at 11 o'clock. And the next one, symposium in October, will focus on ongoing efforts to understand and treat traumatic brain injuries in New Mexico. So if you're interested in TBI, please take a note of October 19th at 11 o'clock. I also put in the chat our website. Our program manager, Faith Brand, put a lot of effort into updating funded opportunity announcements. We have pilot research program. So we would like you to visit the website and connect with us. Today, we have outstanding panelists who will present their research focusing on pain, novel targets for pain research. We'll have two 15-minute talks from senior and mid-career investigators, followed by lightning talks by junior investigators. So it's my pleasure, without further ado, to introduce the first speaker and organizer of this symposium, Dr. Karen Westland-High. Dr. High is a professor and vice chair for research at the Department of Anesthesiology and Critical Care Medicine. She has outstanding research career with over 200 manuscripts, which I've been blown away. We've been cited over 11,000 times, and her age index is 63. She's currently associate editor of a pain journal, among many other accolades. So it's a true, without, again, just because we are pressed in time, without further ado, it's my pleasure to give the floor to Dr. Westland-High and learn about the research in this area. Thank you.
Thank you, Ludmila, and thank you for this invitation to create this symposium and bring our team into focus for you. And we have many other team members who have done outstanding work but these are the ones we'll share today. My talk, and then Dr. Sasha Alas, Dr. Riza Asanian, and Alea Goins. So, all right, so I have been looking at novel non-opioid pharmacologics, developing them for chronic pain, because many people suffer from chronic pain, and including our veterans, where it is predicted by our former head of the Veterans Administration that half of the vets have chronic pain. And many of them suffered this in Iraq and in other situations where they were exposed to blast and frank blunt injury to the face, just like a lot of other Americans who have been in automobile accidents. And it could be from dental procedures or just domestic abuse, where you have frank nerve injury. Of all the injuries to nerves, the head and the neck, and then followed by low back pain, are among the most frequent. So, and they're actually the least treatable. They're either by anti-anxiety therapies or any of the gabapentin, pregabalin, neuropathic pain. They hardly touch the trigeminal nerve injury pains in the face, and opiates of absolutely no use. I don't know why this is slow to change. So another particular reason why we would want to look for a non-opiate therapy for chronic pain is because the CDC has reported that New Mexico is among one of the major states in the United States who have a high rate of opiate addiction and deaths. The 20% of all Americans, 1 in 5, suffer from chronic pain, which is about 40 million people. just does not want to advance. Chronic pain is also linked to anxiety, reduced quality of life, and can lead to sleeplessness, which lowers quality of life, and there's loss of work productivity. And that is estimated at $560 billion annually globally. So it's a very expensive thing to avoid. Now, the substance use disorder is a problem, whether it's come from surgical continuation of opiates, but mostly it is due to pinpointed in the recent literature as centered around low family income has a greater effect than even ethnicity, the lifetime prevalence with Indigenous people. Now, this study was done in Canadian and Australian Indigenous. I don't know, couldn't find a study for the American, Native Americans. And then the distribution with Asians having the least prevalence. And these depression, anxiety, and personality, sleeplessness, and even cognitive deficits can occur with chronic pain. So even when a nerve, which is damaged, is repaired, there is some memory remaining in the nerve, and the continual development, sometimes 2 to 3 months later, of the incidence of chronic pain, to the point of being a major global burden because of the addiction that follows in many cases. So we've come up with a new treatment paradigm for chronic pain. Along with my collaborator, Adi Kunamneni, who's now at Mayo Clinic in Jacksonville, Florida, we developed small antibody therapeutics. Now, the good part is that there is an expanding market of survivors of head injury, post-traumatic injury, post-surgical pain, cancer, chemotherapy-induced pain, multiple sclerosis, HIV. So how did we do this? We took a peptide and we created antibodies to it, but taking only a portion, the binding portion of an IgG molecule, with a special procedure that Kunamneni originated, where this small part is joined by linkers, and this biomolecule, called a single chain fragment variable antibody, is 30% smaller than the conventional IgGs used for monoclonal antibody therapies. This small size conveys better tissue and brain penetrance, better efficacy, and is less immunogenic. We believe that these SCFBs are going to be a good non-addictive biologic. They've been very successful for decades for cancer therapies. And we find in our animal models that it reverses chronic pain, restores nerve function, it would appear, and without any side effects. And we just take an amino acid sequence of our choice and devise these SCFBs. And today I'm going to tell you about the one that we've created for the GPCR cholecystokinin B receptor. Cholecystokinin B is throughout the body in immunological cells, but it is very abundant in the brain, particularly along the pain axis. And the receptor and the peptide greatly increase with brain and nerve injury. Now, this was shown in a previous paper by us that not only does the protein increase, but other people have also seen that the RNA increases in many pain models. And we showed this at 3 days with a 4-fold increase, and then at 21 days, a 2.7-fold increase. And when I'm giving examples of our specific CCKB receptor, you'll see that the addition of the antibody to our animal model greatly brings down the the fold change of the CCKBR, which I'll be calling it. Now the procedure is simple, but it's complex for me to explain it. I picked a peptide fragment, a binding fragment of the CCKBR peptide, and we injected it through 3 rounds of immunization in a mouse. Then we harvested the spleen and extracted the RNA. And with each round, there was not really an increase in the immunology, but there's our 3 COVID shots right here. Hopefully ours will increase. And Dr. Kunamneni put this through a procedure called ribosome display generation of this construct, first by producing an antibody DNA library, and then through all of these different steps, he produces and purifies and recovers with this cell-free process. And then from the DNA, it takes this recombinant into an E. coli system where it is cloned, expressed, and purified. In this portion of the slide, you see the Western blot where he purified 8 different CCKBR specific SCFVs. And then with the immunoblot shows the binding efficacy with his controls, bind specifically to CCKBR and not to CCKA receptor, or these negative controls, including another SCFB to Zika pathogen. And then here are the 3 that we selected, binding very well to CCKBR. They were selected because they had the best binding affinity to the CCKBR. The in silico evaluation that we've done recently shows the interaction between the CCKB receptor peptide portion that I selected, and then this is the SCFV molecule represented here. And the SCFV is shown here, binding to the target theoretically in this, with this portion of the CCKBR molecule that is embedded in a lipid membrane bilayer. So we set about to study this in models of trigeminal nerve injury, which, if you're familiar with the V2, will become sensitized, the V2 fragment of portion of the trigeminal nerve. We had a previous model where we had a surgical implantation of chromic suture, which was very invasive. But with Marina Montera in the lab, we now have one that is quite simple and bloodless, easy to produce. She could produce within 5 or 10 minutes. It's very reproducible, and it persists over 100 days that we've gone out with a neuropathic pain. But the outward sign in the animal is not obvious at all. And so it can be blinded well. Now, the conditions that cause this type of neuropathic pain includes the head injuries, as I've mentioned, blunt force trauma to the nerve on the face, specifically in this V2 region and portion of the upper teeth innervation. Also, some people with diabetes have this injury, shingles, cancer, multiple sclerosis, and other unknown causes, some of which are believed to be a herpes viral infection. So Marina and I developed a model for this in the animals in our favorite characters, the Balb-C mouse and the Sprague Dawley mouse is being tested right now by Sabrina McElrath at the VA laboratory that I have. We call this friction, the foramen rotundum inflammatory compression model of trigeminal infraorbital nerve compression. So this model is, as I said, is quite easy. You just pull back the lip, make a tiny slip with a scalpel, and there you see quite plainly the innervation of the teeth. And she slips this 3 millimeters of chromic gut suture along the nerve. and it produces a sensitivity in this region of the mouse face or the rat face. And with these fine filaments, we can test the baseline sensitivity on the mouse face, which gives us a very clear evidence of the pain level. So this is model induction. We wait 3 weeks so that the hypersensitivity that develops is on a plateau phase. And then we give a single dose of the viral of the SCFB, and we let the animal, over the next week, the hypersensitivity is reduced. And at a later stage, we test anxiety and depression. And we tested the 3, and of the 2, with the highest binding affinity, were the most effective. We've done dose studies, and all doses were equally effective except for a very low dose. It was equally effective in males and females, and they were also sensitive to cold, but it was reversed by the SCFBs. This is also a symptom of patients with this trigeminal nerve injury. Anxiety was shown with the 0 maze, and it was the time of which they stayed in the closed area was increased, and the time that they roamed around was lessened, but a single dose brought that back to baseline. Depression was tested by a 10% spray of sucrose onto the rump, and the normal animals will lap it up readily, while the animals with neuropathic pain do not. They sit quietly most of the time, but the the SCFB reversed the hypersensitivity. Another test was light dark exposure. They stayed in the dark if they were in a pain-like situation, and it was brought back to normal by the SCFB. There is no addictive properties like there is with morphine. And cognitive ability, which is decreased among conditions of pain in humans and in these mice and rats, was returned to normal with the novel object recognition test. Western blots showed brain penetrance, not only in the medulla as shown here, but also in the trigeminal ganglia themselves. And this was estimated using a histag positive control to be 3.2 micrograms normalized in the medulla, which is where the trigeminal nerve innervates the brainstem. We did a PCR, RT-PCR, and we show the data here. This was recently published, so I will dwell on this, but again, it shows that the expression fold change was decreased. I'm running out of time here. So if you put the trigeminal ganglia into a dish, we could stain them for the CCKBR receptor, and without a pre-block, we see an abundant amount, but with increasing doses of the SCFB, there was less staining with the receptor for CCKB. This slide you'll have to ask Sasha Alice about, but basically he took these cells and did his patch clamp recordings, and the CCKBR SCFB reduced the spontaneous firing frequency of the trigeminal neurons that were taken at week 3 from the mice with the friction model. The firing frequency was more significant when the antagonist CCKB8 was given, shown here. But the real base was not significantly changed. In summary, the ribosome display method used to produce this recombinant antibody and selection, and then the SCFB generated targeted, in this case, the CCKBR, and we have several others coming along behind it. These engineered SCFBs have a strong affinity and increased tissue penetrability due to their small size compared to monoclonal antibody therapies. We found a single dose reduces the animal model hypersensitivity, anxiety, and depression do not develop. There were no side effects, and there was no addiction potential detected. And the improved cognition was very obvious in these animal models. Sasha Alice and Alea Goins found that the reduced neuronal firing frequency in the treated cultures from the mice with friction was reduced. And the CCK-BR SCFD, we believe it will be one of an ideal treatment for the neuropathic pain, nociceptive, and the emotional components, which are a huge portion, a huge component of pain that persists beyond 2 to 3 months. This is the team. We're currently humanizing variants, our favorite variants, I should say Kunamneni is, so that they can be tested and moved through, hopefully, to IND status in the next few years. The animal models were developed and validated by Marina Montera. Alea Goins, as I said, did the patch clamp recordings and is a new graduate student here at UNM Graduate School. Sasha Alice is clearly involved in his use project, and you'll hear another one of his projects next. Ian Adams was just hired as a research assistant who has learned already in a month patch clamp recording the animal models and the validations. Mitra Agafol-Becklin, I've left the L out of her name for some reason, has learned the cell cultures, does the Western blots, and the immunocytochemistry. Our current chair, Chris Arndt, has been extremely supportive, as has the past chair, and Hugh Martin. And eventually, we were hoping that our partner, Eugene Koshkin, the director of the Chronic Pain Fellowship Program at the Pain Center and Neuroscience Center, will be able to test these antibodies in the near future. Thank you. Are there any questions?
And maybe we can take questions at the end and ask participants. Put them in the chat so we can consolidate because of time.
Yeah, because we're running behind. The next talk will be by Sasha Alice, assistant professor, has been here 2 years at UNM. He received his BS in biochemistry from Imperial College London, his PhD in neuroscience from the University of Alberta, Edmonton, Alberta. He is a Canadian. He did postdoctoral work at the University of British Columbia, Vancouver, the University of Alberta, and University College London. His funding is our funding. All of our funding is the DOD, and hopefully by tomorrow, another pending grant. He has 18 publications and many other accolades, which we don't have time to go into. There you go.
All right.
You have to push this in order to
Push down.
Yeah.
All right.
I don't know why.
So I'm coming in here just to control the slides. All right.
Yeah, Sasha's here now.
All right, so I'm going to talk about a target we're very interested in the lab. It's an amino acid transporter called SLC7A5 or LAT1 as a target for chronic pain therapeutics. I have no financial disclosures. As you heard from Karen earlier, what is pain? Acute pain is essential for protection. It's short-lasting. Inflammatory pain protects the region, allowing for repair, and it's often short-lasting. But what we're most interested in the lab is studying chronic pain, and in particular, a subtype called neuropathic pain, which is intractable, non-essential, and it's often caused by nerve damage. Why do we study it? Non-addictive, non-opioid replacements are urgently required because of the opioid abuse epidemic. It's estimated that about 20% of adults in the US have chronic pain, and that number is similar globally. So about 1 in 5 people, about 3 million new cases of chronic pain in the States added every year. And it's the most common cause of long-term disability. So before we talk about chronic pain, we need to understand what nociception is. Back in the 1600s, René Descartes first described nociception as fast-moving particles of fire that disturb the filaments in the nerve. And that definition was refined almost 300 years later by Sherrington, the British neurophysiologist, who defined it as a process that in which a noxious stimulus is detected through nociceptors. And so The nociceptor, it comes from the Latin word nocere and receptor, so nocere meaning to harm. It's an analog to digital converter, so these rely on free nerve endings in your skin, for example, and tissue. That would be your analog input, would be your damage-causing stimulus, such as mechanical force, heat, cold, or some kind of chemical. It converts the noxious stimulus into an electrical signal, which is the digital output, and generates action potentials, which are your all or nothing responses. And there are three main types of nociceptor. There's unimodal that respond to one type of stimulus, polymodal, more than one type, and silent nociceptors, which are perhaps most interesting in terms of chronic pain, that change in response to injury or, in fact, repeated stimulation. So for chronic pain, you need four main steps. Transduction, you have action at peripheral nociceptors, so that you can measure action potentials in the periphery. You have conduction along those primary afferent fibers and its synapses in the superficial dorsal horn, where you can also record action potentials. You have perception in the higher brain centers, and then, of course, modulation, top-down descending circuitry. And so that encompasses all the things required for pain and chronic pain. So transduction, conversion of those noxious stimulus to a cellular response, just giving you an idea of how that can be measured. It's graded by stimulus strength. So in response to a stimulus, you can measure action potentials. And conduction, which is where our kind of zero in on, and that's what we're most interested in the lab as an electrophysiologist. I'm mainly interested in studying the changes in excitability of these neurons, the dorsal ganglion neurons. So we study the action potential, which is the all or nothing response here. You have different sodium channels that are responsible for this upstroke. Nav 1.9 is responsible for setting that resting membrane potential. Nav 1.7 in that upstroke sort of ramp phase. 1.8 in the threshold, and you have different potassium channels, of course, involved in the downstroke, and then T-type calcium channels involved in setting burst firing, so you can have multiple firing as shown depicted in the bottom right corner there. So I'm going to just talk a little bit more about Nav 1.7, and why I'm most interested in that is because I spent a lot of time working on it when I was a postdoc. But it's particularly interesting because you have these extremely rare people who experience congenital inability to experience pain, congenital insensitivity to pain, or CIP, caused by mutations, loss of function mutations in the gene that encodes Nav 1.7, SCN9A, and it was first identified in families in Pakistan. And numerous cases have been reported since. So gain of function actually causes extreme pain, and loss of function causes loss of pain. And what the drug companies have been trying to do is develop blockers, logically, because people that don't experience pain have loss of function. So naturally, if you block it in somebody with extreme pain, maybe it would work. However, the story about Nav 1.7's involvement in neuropathic pain and chronic pain is slightly more complicated. So in terms of chronic pain, you have a lot of things going on. Inflammatory mediators, cytokines like interleukin-1 beta, release of things that switch on these microglia. There's another target work on the lab, P2X4, which is a purinergic receptor, involvement of neurotrophic factors in the spinal dorsal horn. And some seminal work from John Wood's lab has shown that, in fact, knockout mice of Nav 1.7 and Nav 1.8 seem to develop neuropathic pain normally, and it doesn't seem to be involved in chemotherapy-induced neuropathic pain. So not clear that it's involved in neuropathic pain itself. However, one of the first labs to kind of look at interacting proteins, Rajesh Khanna's lab at the University of Arizona, has shown that perhaps interacting proteins may help unlock Nav 1.7's potential. And so one he focused on here is CRMP2, or collapse and response mediator 2. At the same time, there's this study, again, from my postdoc work, or some of my from my postdoc lab using an epitope tagged NaV1.7 mouse. Ion channels are notoriously difficult to study. And so introduction of this TAP tag allows one to perform a pull down assay and look at interacting proteins. Long story short, basically this mouse, you pull down NaV1.7 with affinity beads attached to its interacting protein and run mass spectrometry on the interacting proteins to see what the interacting proteins are. And it does nothing to pain behaviors. This mouse is otherwise normal or the function of the ion channel. And so when I was analyzing this list of interacting proteins, the one that really stood out for me was this one called SLC7A5, which wouldn't mean much to a lot of people, but I spend a lot of time working on the gabapentinoid drugs, which are first-line treatments for neuropathic pain. From my earlier work, I knew that this LAT1 protein, or SLC7A5, is actually the transporter for gabapentin, and it's how it actually gets into cells. Looking at it more closely, looking at the literature more closely, some other groups have also identified that LAT1 interacts with potassium channels, and of course NaV1.7. So it is well poised to be involved in chronic pain, and we actually wrote a review on that came out last year. So we decided to look a little closer and look at what blockers were available. So we have this model here, a spared nerve injury model, where the animals develop neuropathic pain. It's a very commonly used model in the fields. You see this red line in the corner here showing that they have a reduction in this mechanical threshold, showing that they have neuropathic pain. And so giving a systemic injection of this blocker, which is actually being developed as a drug for treating cancer, it increases the paw withdrawal threshold in mice. And you can actually increase the size of that effect. So we got together at the Kana lab, and he has these rats with catheters, and providing a spinal injection, it seems to work a lot better and need a lot less. Looking at the levels of the protein, it's actually upregulated in the SNI model. We had some spare tissue from some other mice, these are mice that were treated with an anti-allodynic drug, which happened to be a CCK4 inhibitor, and found that the levels were reduced of this transporter. So in our preliminary data, showing that it seems to be poised to be involved in neuropathic pain. So we looked at some of the nociceptor excitability, and it's not clear that it's involved peripherally because there was no effect on the resting membrane potential when the cells were treated with this LAT1 blocker. However, we did see some slight difference in the proportion of neurons that exhibited multiple firing versus single firing when depolarized with the current ramp. We still have more experiments to do, so we're doing further work to look at the central mechanisms by recording from spinal cord neurons from ex vivo slices from SNI neurons, and this work was done by Aaliyah Goins. And so we have a lot more work to do, but one of the biggest issues I think with doing this project with a drug, with this particular drug, is that it isn't great. It hasn't been it's not very specific, and it's somewhat of a dirty drug. And Rajesh's lab over in Arizona, he has access to these medicinal chemists and computational modelers. And so we're working with them to develop, to look at existing drugs that seem to affect the interaction between SLC7A5 and its binding partner, SLC3A2, to disrupt its function. And so we've put in a grant to study that. We're also working, this use of these human-induced pluripotent stem cell-derived neurons is involved, is in a number of projects in the lab. The reason we're using these cells is because we really need to treat pain in patients. And so, you know, having it in rodent models is all well and good, but we really need to figure out whether it's doing anything to the function of human-derived nociceptors. And we're able to grow these cells provided by a company for a week, and they start off looking spindly shaped, very immature, not firing action potentials. And after about a week, they're firing action potentials and then eventually burst firing. And what's great about the system is we have some RNA-seq data to look at the expression of different targets, and they express all the calcium channels, sodium channels, TRPV1, so they're responsive to capsaicin, and the amino acid transporter SLC7A5, so we can study it as a target. How are we doing for time? Okay. So we're also working with the Hoppe lab, Mike Hoppe's lab at Dartmouth, to study the axonal AP propagation using an all-optical approach, using voltage-sensitive, genetically encoded voltage indicators, such as quasar, shown here. And the great thing about this technique is it's higher throughput than whole cell patch clamp, and we can also look at axons of DRG neurons. And so we're looking at that as another screening approach to test how effective potential novel SLC7A5 blockers are in inhibiting action potential propagation. Okay, and so yeah, that work was mainly, most of the work presented there was done by Aaliyah Goins, who was a technician at the time, but is currently a grad student in the BSGP program. We have a growing lab. We have a new postdoc joining the lab, Justin Levine, next couple weeks, in the next 2 weeks. A technician, Ian Adams, Mitra is an undergrad in the lab, and Marina is our master of all trades, a lab manager and technician trainer. So of course we collaborate with Karen's lab, and Reza will talk about some of the collaborative projects we do, and with Dr. Koshkin, Adi Kunimeni, and Rajesh and Mike, of course, and thanks to the funding from DOD and soon NIH and the endowment fund of the anesthesiology department. All right.
Next will be Reza Essanian, MD, PhD. He's a PGY4 resident here at UNM in the Department of Orthopedics and Rehabilitation in the Division of Physical Medicine and Rehabilitation. He received his BS in 2000 at San Jose State University, California. He worked for 6 years at NASA Ames Research Center at Mountain View, California, where he was involved with the vestibular biophysics lab. He started a master's in 2008 in biological science, physiology, and a minor in chemistry, where he completed his PhD in 2010 at the University of Oxford for both and all of that. He received his MD in 2013 from Stanford, and he's done residency, postgraduate work at Vanderbilt University, worked at Santa Clara Valley Medical Center in San Jose, Case Western Reserve University, and now here at the University of New Mexico School of Medicine. He has 31 publications already, 42 meeting abstracts, and 1 book chapter. He has 2 clinical studies working with Eugene and Sasha, and clinical samples of blood, CSF, and herniated disc material, 5 clinical trials. The most interesting one to me was his electrical stimulation for continence after spinal cord injury, and then also 2 animal clinical models. So go for it, Lisa.
All right, well, good afternoon, and thank you for joining us at the BBHI Symposium. I'm honored to speak with you about our work in the Department of Anesthesiology. Today, I'll be speaking to you about a translational project and introducing you to the term B2B research. Next slide. Next slide, please. So in order to put the talk into context, I'd like to review with you part of the research mission of the department. Our ultimate mission is to develop non-opioid-based pain treatments in order to address the opioid abuse crisis. To achieve this mission, we aim to elucidate the molecular mechanisms of nociception and chronic pain with the specific goal of discovering novel treatment targets. Next slide. We hope to accomplish this by conducting translational research. So traditionally, translational research is described as bench to bedside research, where an in vitro discovery is investigated in an animal model, then translated into clinical trials in hopes of developing novel treatments. Next slide, please. That model has been updated to reflect the fact that sometimes clinical studies and observations are translated into the basic science lab to inform in vivo research, which are then tested in animal models to serve as the basis of clinical trials. Next slide, please. However, I'd like to present to you a new way of thinking about this collaboration, a B2B research model. In this model, there is constant crosstalk between basic scientists and physician scientists, each informing each other in order to more efficiently translate novel treatments into the clinical practice. Next slide, please. So I grew up in a family of construction workers, so please excuse the simplified analogy. However, I hope that it helps me express the concept of why a B2B research model is important and what ultimately makes it successful. The way I like to think about it is that we're trying to move a large boulder that's representing novel pain treatment over a mountain, which represents the development hurdles, into the other side where there are patients in need. To do this, we need the push of basic science and basic scientists. Next slide, please. However, to be efficient and to help ensure success, we need the pull of physician scientists and buy-in from the clinical department and program in large. Next slide, please. Finally, and maybe most important, we need administrative, departmental, and university support to level the mountain and lower the hurdles faced by scientists, clinicians, and the system at large. Next slide, please. Currently, we have several active projects for which we're trying to implement the B2B research model. I'd like to present one project to you today. And if you're interested in details, this lightning talk is not for you. I want to direct you to the publication we have. Next slide, please. So at about 1 or 2 a.m., we were presented with a patient undergoing active opioid withdrawal due to presumed implantable drug delivery system failure. Here you see studies where we investigated the IDDS and found no visible issues with the pump or associated catheter. In doing the interrogation, we were able to attain CSF from the patient presenting an active opioid withdrawal. Next slide, please. After an overnight stay, the patient was controlled with oral medication and was no longer in withdrawal. However, we needed to take her back to the OR to replace what we assumed to be a faulty catheter. There, we were able to obtain post-opioid withdrawal CSF and blood samples. Next slide, please. Using CSF samples, we were able to perform electrophysiological experiments. And because of time, I'm not going to get into what all these panels mean. I'm just going to have you focus in the panel D and E. We see significant increases in peak amplitude and area when the patient was going under opioid withdrawal. So this is indicative of modulation of ion channel activity, controlling the action potential shape that may lead to increased excitability when the patient is undergoing opioid withdrawal. Next slide, please. Using the pre and post opioid withdrawal CSF samples, we studied cytokine levels. Of the cytokine levels detected, there was no significant difference in any of them, unfortunately, pre and post withdrawal. There was a significantly higher level of MIF when compared to other cytokines. And MIF has been implicated in pro-inflammatory signaling and activation of sensory neurons. Next slide, please. So in conclusion, our study showed that treatment of in vitro neurons with CSF pre and post withdrawal resulted in differential neuronal excitability, which may account for some of the symptoms of opioid withdrawal. We also hypothesized that possible differences of CSF cytokines pre and post opioid withdrawal may be more complicated than previously postulated, as we didn't find any differences. However, the most interesting thing about this is there was a constant communication between me, Sasha, Dr. Koshkin, the basic scientists and the clinical scientists, And we determined that it might not be the fact that there is no CSF change. We might have to tweak some of the basic science in vitro assays. Next slide, please. So I'd like to thank my mentors and the collaborators, Dr. Koshton, Dr. Grande, Dr. Valeriano on the clinical side, and also Dr. Hyde, Dr. Ailes, and Dr. Peterson in the basic science side. I think we have a very, very special program here, and I'm very excited with some of the basic science and translational work and clinical work we're about to do in the upcoming years. Next slide, please. Thank you. I invite any questions.
All right, so we'll do the questions at the end, and now moving along to Leah Goins, our new UNM first-year grad student. She worked from 2012 to 2014 as a lab technician in Colorado College Biochemistry Department. In the summer of 2013, she worked at the Mind Research Network under mentor Arvind Kaprahan, learning basic coding, and worked in Python to assist him with the hundreds of MRI images that had the problem of a shaky table to try to pull the data from that. 2014 to 2016 at Colorado College IT, she was a help desk specialist liaison, providing technical support to the students and faculty, and maintained the campus-wide printer system. 2014 to 15 at the Colorado College Admissions Office, she was outreach and access coordinator, recruiting students and first-generation students. She has her BA in 2016 in Spanish language and Hispanic studies. And in 2018 to 2020, she here at Albuquerque, she gained her prerequisites for graduate school from Central New Mexico Community College, where she was on the dean's list. And here at UNM, while she worked for us 2 years as a research tech 2. And but in this time, in 2019 to 2021, her patch clamps have contributed to 4 publications. Alea?
Hi, everyone, and welcome. And I appreciate the support for this team because it's an amazing team, the anesthesiology department, and on the clinical side and on the bench side. So thank you guys for giving me that introduction and including me in your work. So I just want to talk about a very specific peptide, and the sake of time, I'm going to be focusing on just some experiments that we performed in lab. And I want to just give you the table of contents really quick. So we're going to be looking at the friction pain model, and Dr. Haya given a really good introduction to that already, so I won't spend too much time on it. I'll look at the RNA-seq analysis, some behavioral effects such as the anti-allogenic effects, protein interactions such as a Western blot and immunostaining, the electrophysiological effects, and then throughout all of this, I want everyone to keep in mind that we saw sex differences. And so this could be a potential future direction in looking at the differences of how pain medication affects males and females. And so that we can develop a system for more individualized medicine and less kind of like shooting in the dark when it comes to prescriptions. So that would be a really awesome place to look for this. Next slide, please. And then one more. There you go. So Sasha Alice had looked.
Sorry.
So Dr. Sasha Alice had already talked about the NAV 1.7 and the others. Right now, I'm going to be talking about CAV3. And so without going into too much detail, since this is a lightning talk, we use the TAT-based cell penetrant system that develops a positive and then also a negative peptide. So you're going to be looking at treated versus control in the future experiments. And in the treated, the peptide was developed with a carboxyproximal region that's able to bind to a CAV3.2 and CAV3.3 receptor on the surface of the cell membrane and penetrate the cell. And so by binding, it's going to be blocking. So in this instance, whenever I say a treated condition, it's really a blocking peptide that's going to be blocking the function of the receptor. And then on the control, just to eliminate any potential side effects of the TAT-based system and these modified peptides, we're going to be, it's the same kind of components, except that it does not block. And so we can go ahead and go to next slide. And so this is the friction study, and I love the name because that's exactly what it does. And so Marina and Dr. Hai developed this system and this model, and it's really amazing. Marina was able to teach it to me in less than a week and have it kind of like fly off, and it's just extremely reproducible and extremely easy to perform. So we just do a small incision into the foramen rotundum inside the cheek, as you can see in the graphic, and then we insert about a 3mm chromic gut suture. And so the mouse surgical incision will heal within the week. And so it'll have no side effects from the actual surgery, but as it's eating and chewing and playing and cleaning itself, it's going to be experiencing that small amount of friction against the trigeminal nerve. And so we're looking at trigeminal nerves because we're interested in trigeminal neuralgia. And as Dr. Hai already talked about, it affects lots of people. Trigeminal neuralgia is really prevalent in women, and especially women over 50. And the causes are mostly unknown unless it's due to injury or disease like a viral infection. Next slide, please. So why CAF 3.3? Because whenever the lab ran an RNA-seq of whole TG from friction mice, we saw that there were several upregulated genes that were related to ion channels. So one of them that had really high significance was CA-CNA subunit 1I. And so that's a calcium channel, low voltage dependent alpha 1 subunit. And so this gene and then its expression of a calcium channel is really is not well understood in relation to pain, but it's really well understood in relation to like epilepsy and different neurological disorders. And so it was really cool to like be kind of on the forefront of looking at how can it relate to pain and how to develop this TAP-based cell penetrant peptides, which we were able to, we cited this other paper by Marco and Weiss, and Robert Weiss. And so really recommend looking at that for some more background information on the peptide itself. Next slide, please. So these are the behavior results. And so we saw anti-allodynic effect, which is essentially saying that these mice develop a sensitivity. And so, for example, trigeminal neuralgia, it's kind of a type of pain that is shooting and sharp, but it's stimulated by very, very mild stimulation. So just like a brush of your cheek or a strong breeze in the wind can trigger it, and it can come on really strong and then die off really quickly as well. So we wanted to mimic that kind of experience, like what people would be experiencing in real life, that on the mice, by just using a Von Frey application with light taps to test their sensitivity, not necessarily deep pain. So these mice are experiencing very light taps, but you can see that, and I don't have access to the pointer, but you can see that the green lines are that, here we go, are the treated, and then the pink lines are the controls, and then blue is naive. So these mice have not had surgery or any drug. So what was really interesting is that there's an obvious significance that this treated condition gives them a big relief. But what was really cool to see is that it gives the females slightly more relief than the males. And so with that in mind, we've conserved the design model to keep testing males versus females throughout the experiments. Next slide, please. And so we wanted to look at the protein expression. So we found that females showed a greater decrease in signal intensity than males, and which means that they had lower levels of the CAF 3.3 protein than males, but the CAF 3.3 blocking peptide reduces expression of the channels because it's blocking it. And so we can see that in the immunostain that there's less green in the treated condition versus the control, which just represents that those channels are being blocked. And then you can see it quantified in the intensity and normalized ratio between the control and the treated. And then, and thank you, Sabrina, for the work that she did to help us get these images. They're really beautiful. And these images came from cells that were cultured in DMEM media for 24 hours, and they were isolated, disassociated and isolated with enzymes, and then fixed and immunostained. Next slide, please. So this is the rig, and thanks, shout out to Ian, he took this picture for me yesterday. But this is kind of what the standard setup looks like when you're going to be performing whole cell patch clamp recordings. And so I wanted to give a quick summary on what that is. So essentially the cell is a ecosystem of itself. So it's a closed system. And even though it's porous and has all these channels that interact with its environment, it's actually a beautiful system that's protected. So in order to measure what's inside that system, we use a glass pipette that has an electrode threaded through it. And then we put internal solution that mimics the same conditions as inside the cell and inside the glass pipette. So this glass pipette has been pooled so that it has a tip where the diameter is about 2 to 4 microns. So you can see that in relationship to the cell size itself. So the neuron's about 28 microns in diameter. And so the tip's about, between 2 and 3. So we lower down, so it's kind of like, I think in the picture, you can see that there's controls. And so I really enjoyed recording because it definitely felt like a video game at times where once you get the pipette into focus over the cell, I look at the screen, and then it's a matter of controlling the remote, and you lower it on, and then you use a mouth pipette to give it a gentle suck, and you can break through the cell membrane and lower the pipette further into the cell without actually destroying it. Is really the challenge, but being very, very gentle. And then after you give that small suck, it creates a gigasil. So it becomes a closed system of the pipette inside of the cell. And this allows us to measure electrical activity inside the cell. So with that in mind, once we can apply drug into the bath, the solution that it's sitting in, and then the CAV 3.3 blocking peptide will interact with the surface of the cell, but we are going to be recording the activity that's inside the cell. So next slide, we can look at the data from that. So we're going to be looking at, and on this slide, we're looking at resting membrane potential. And so we saw that there was significance in females and that they had a lower resting membrane potential in the treated condition versus the control condition. And you can peek, and I wish I had the pointer, but you can look at the control condition for females versus the control condition for males. It's roughly the same. So the cells, the female cells and the male cells had really similar conditions, really similar like status and health. So they were comparable, but we can see that there's a greater effect of the blocking peptide on the females versus the males. But the males were trending in a positive direction. So I wouldn't rule it out that it was ineffective. It just wasn't effective yet. We could do some more experimentation there. And then below are current clamp traces shown for stepwise current injections, -100 to 190 picoamps. And so the context for that is whenever we lower the pipette into the cell, we inject it with a current to stimulate the cell to fire these action potentials. And so you can see the shapes of them. And even though in the female traces, there's multi-firing, you can see that the bottom line is very smooth all the way across. And then in the male line, there's a sag in the beginning of the trace. And so we call that the sag ratio, which kind of gives hint that these male cells had a higher sag ratio. So there could be some other ion channels in effect here, or there could be just something special about the males versus the females, which again, that's a future direction, which I'm pretty interested in. Next slide. And then this is going to be my last data slide. So some more electrical physiological effects that I found pretty cool was that the prevalence of spontaneous activity in these trigeminal cells under the treated versus the controlled conditions. So in figure A, you can see that there's a 1-to-1 ratio between non-spontaneous activity and spontaneous activity for the control females. And then whenever it's treated, you can see that the non-spontaneous activity increases and the spontaneous activity decreases. So for context, spontaneous activity is recorded from a gap-free current clamp recording while we artificially hold the cell at -45 millivolts. And so all we're doing is priming the cell to fire, but we are not eliciting that firing. So this is the cell acting kind of on its own accord. And we're kind of just like, instead of manipulating the cell, we're just kind of putting on binoculars and watching it. And so on its own, these nociceptors are just going to be firing on their own, even at a primed state. So, and this kind of translates clinically that these nociceptors and your trigeminal nerve in your face, you're going to be experiencing pain despite having no stimulation. And that's kind of a character trait of chronic pain, is that the pain is persistent. So we can kind of make these little bit of make these parallels between spontaneous activity and that pain that just happens, that these nociceptors are just firing without any real reason or known reason. So and so in the female and male treated conditions, there are fewer neurons exhibiting that spontaneous activity. And then next slide. And then thank you for coming to this talk. I really appreciate the opportunity to speak, and thank you to the team, Sasha and Karen, Marina, Sabrina, Mitra, the anesthesiology department, like Dr. Koshkin. And I want to make a particular mention that this is a pain model. So we did have to induce pain and hypersensitivity in the mice and then sacrifice them for recording. So I just wanted to give a shout out to always appreciate the animal model that had to go through being sacrificed to get the data. And that's the talk. Thank you.
Thank you, Aliyah. So we have a few minutes left, or not, if you would stay, if you have any questions for any of these speakers. If not, then we thank you for this opportunity to share our work with you today. Thank you very much.
Thank you, everybody. Bye.
Bye-bye.
Have a great day.